Welcome to our Bad Gut webinar on inflammatory bowel disease. This webinar will focus on questions that you have sent in to us and need answers from both a gastroenterologist and a registered dietitian. So today we have with us Dr. James Gray and Beth Nanson, who will be focusing on answering these questions that are very important to you. So Dr. Gray, before we get into the questions that people have asked us about, what they want to know more about, why don't you give us just a little overview about what is inflammatory bowel disease so that we have the basis to go from?
That's a great question because a lot of people, I think, get mixed up. They hear a lot of different terms, and IBD, which is inflammatory bowel disease, and IBS, which is irritable bowel syndrome, and they're completely different conditions. So IBD, which is what we're talking about today, is inflammation of the bowel, and there's two main forms of it. One is Crohn's disease and the other is ulcerative colitis. Ulcerative colitis involves inflammation of the lining of the colon, so that's the lower bowel, and typically it begins in the rectum and then rises up through the colon, causing the lining of the bowel to become inflamed, which then gives symptoms like diarrhea, bleeding, cramping, urgency, false alarms when you're going to the toilet, and it's all related to this inflammation of the lining of the bowel. Crohn's disease, on the other hand, is an inflammation of the bowel, but it's a little bit more deeper into the wall of the bowel. It can involve any part of the bowel, all the way from the mouth down through the stomach and the small bowel and into the colon. Most commonly involves the small bowel, and the inflammation causes the same sort of symptoms of diarrhea, cramping, and pain. But it can also affect nutrition because the absorption of our nutrition is primarily in the small bowel. So if the small bowel is inflamed, then that inflammation can reduce the nutritional absorption of the GI tract. Nobody knows the cause of inflammatory bowel disease. Lots of speculation, and we know that it's increasing around the world. The prevalence of inflammatory bowel disease is highest in North America, but now it's growing in other parts of the world. Reasons for that aren't clear, perhaps related to lifestyle changes, dietary factors that aren't clear. We know that there's genetic factors, and there's a number of different genes that have been identified that are related to inflammatory bowel disease, but they're not necessary to be measured. There's no real use in measuring them. So there are clearly genetic factors, so that if you have a first-degree relative, that's a mother, father, brother, sister, or a child with inflammatory bowel disease, your risks increase somewhat. But it doesn't mean you're going to get it. It's not contagious. There's nothing that causes inflammatory bowel disease. You don't pick it up from your spouse or your family member. So ultimately, we don't know the cause, but the effect of it is this inflammation of the lining of the bowel that's a lifelong condition. There are wonderful ways of treating it. Some people need a lot of treatment. Some people need a little bit of a treatment. Some people need treatment quite regularly. Some people need treatment intermittently, but it's variable, and it's a question of getting to know your disease and how to manage it. And the management is basically combinations of lifestyle changes, medications, and there's a whole range of medications and increasing numbers that are becoming available. And then paying attention to the consequences of having an inflamed bowel, like dealing with the nutritional consequences, the emotional consequences. It's frustrating if you've got diarrhea, and it can affect your ability to socialize in interactions with your family and work. So trying to recognize the effect that the condition is having on you, and then how to modify those changes. And using the support of your family, your workmates, the support of your physicians, your healthcare providers, your dietitians, physiotherapists. There's a whole range of support that's available to try to manage the symptoms, and it is very manageable nowadays.
So Dr. Gray, what is a real expectation for the course of IBD?
Yeah, that's a good question, because a lot of people wonder when they've been diagnosed with inflammatory bowel disease is what's going to happen to me. And we know that inflammatory bowel disease, whether it's Crohn's disease or ulcerative colitis, is a chronic condition. So there is no real cure for it, but there's many ways of trying to control it, and they include medications, dietary changes, lifestyle changes. And the expectation is that the symptoms are controlled. So for most people with inflammatory bowel disease, they have symptoms of diarrhea, pain, and the main goal for most individuals is to control those symptoms. And then we move a little bit beyond that, and the goal is also to control the inflammation. And so we try to control the inflammation by seeing it gone with a scope or an X-ray, and then ultimately the goal would be to see it gone microscopically so that the inflammation is completely resolved. And we think that's the ultimate goal in management of inflammatory bowel disease, and it's a realistic goal with the tools that we have available to us now.
So how do you go on to determine whether healing has occurred microscopically?
Inflammatory bowel disease is an inflammation, and so that inflammation can usually be seen by scopes, which is cameras in various parts of the bowel, and we can see the inflammation. It's also apparent under the microscope to our pathologists, and so the goal is to control the inflammation in the bowel, which is the problem when people have inflammatory bowel disease. And how do you know if the inflammation's gone? You can tell to some extent by the symptoms getting better. So if the cramping and the diarrhea is gone, you feel better, you feel stronger, that's a good indicator that probably the symptoms are controlled. However, often we do need to look at other more detailed investigations, and that would include perhaps repeating the scopes, using markers of inflammation. So we have inflammatory markers in the blood, we have inflammatory markers in the stool, CRP and fecal calprotectin, and these are very useful tools to show that the inflammation is improving or has gone away. And there's more detailed tools that are becoming more available, such as small bowel ultrasound, that can use ultrasound tools to look for inflammation within the bowel and also to show that the inflammation's under control.
That's really interesting. When we get questions in the office, it's often around, can I stop my medication now that I'm feeling well? And I wonder if you could just address that.
That's a very common question for people that wonder, now I feel good, and maybe I'm good, I don't need these medicines, and I don't really want to take them. Our feeling is that inflammatory bowel disease is a chronic condition, so the medications control it, the lifestyle changes control it, the dietary changes all control it, but they don't cure it. And so the inflammation potential is always there, and so the medications work to control the inflammation, but they also work to maintain that control. So our feeling is that one would be best served to continue the treatment that's got you there. So whether that's medications, lifestyle changes, dietary changes, that whole package of things is very important to maintain to keep control of it. I liken it to things like high blood pressure or asthma or diabetes. These are chronic conditions that you take medicines, you control your blood pressure. You don't stop the blood pressure pills simply because your blood pressure is now normal. It's normal because you're taking treatment, and so therefore you should continue that treatment to maintain that control. And the treatments come in so many different phases. There's medications are very important, and then there's lifestyle changes. Stress management may play a role. Dietary changes also play a role. So these are all things that need to be brought together to maintain the control of an individual with inflammatory bowel disease.
So one of the things that patients have called us about, and we actually got several questions on this during registration, about the effects of the medications on bone health. So I wonder if both you, Dr. Gray, and Beth Nanson would be able to talk to that issue around bone health.
Well, from my perspective as a physician, bone health is clearly important in many different disease states, and very much so in inflammatory bowel disease. I think we see issues with bone health related to nutrition, and we know that people that have trouble with their gut often will have nutritional deficiencies, either because they're not able to eat or they're not able to absorb properly, and these need to be addressed. But there's also issues around other things that affect bone health, like medications, and we know that steroids, so prednisone and other forms of steroids, can have a wonderful effect on controlling inflammation, but one of the side effects is the detriment to bone health and the reduction in bone health. And so you need to recognize that medications have a mixed blessing on the effect of your control of your inflammation, but also the effect they may have in the bone. And to some extent, people with inflammatory bowel disease are perhaps less physically active, and we know that physical activity is very important for bone health.
So Beth, do you want to add some things for that?
Yeah, I mean, our two main nutrients for bone health are going to be calcium and vitamin D. So those are the two nutrients we really want to focus on, especially when we're on medication that can reduce the absorption of those nutrients. That's going to impact our bone health overall. So vitamin D, really hard to get through food. We do get some through the sun in summer months, through the synthesis in our skin. However, when we're wearing things like sunscreen and hats and clothes, blocks all that synthesis. And of course, we don't get much here in the winter months. So that's one we're going to take a supplement of. Calcium, on the other hand, can be quite easily met through the diet as long as we're not restricting lactose or dairy foods. So things like yogurt, cheese, and milk can all contribute to our calcium requirements. And if we're unable to meet calcium through diet alone, we can also consider a supplement. We just want to make sure we talk to our physician and dietitian about the type, because certain supplements aren't absorbed as well as others, and we don't want to be too high in a calcium supplement either.
Do you think everybody should take a vitamin D supplement?
I do.
And how much would you give?
I would give 1,000 IUs in the summer months and about 2,000 IUs in the winter months. So that stands for international units, and that's the units that vitamin D is measured in.
Is it worth measuring the vitamin D levels? A lot of people ask about that.
You can get them measured in the blood, absolutely, and that's a good way to see if we are low. And if we are, we might supplement a little bit higher and do a repletion dose for a couple months before we continue that maintenance dose.
Is there any harm in taking calcium regularly, if supplementing with calcium?
As long as it's not too high. If it's a really high dose in supplements, we risk calcification of our arteries. It would have to be pretty high to do that. We also know that we don't absorb more than about 500 to 600 milligrams of calcium at a time. So that's a good kind of maximum to consider.
And you don't need to measure the calcium levels. We're not talking.
No, our blood doesn't actually correlate to our dietary calcium. So our blood will be a very tight range of calcium, and it'll pull out of our bones to maintain that tight range. So it doesn't have much to do with the dietary intake. We just want to make sure we meet our needs through the dietary intake, but we can't measure that through the blood.
So Dr. Gray, one of the questions that came in is, what are some of the signs that my disease is not well controlled, and what do I do about it?
So inflammatory bowel disease is inflammation of the lining of the bowel, and it may be different areas of the bowel, and the symptoms may vary depending on which part of the bowel is inflamed. So typically the inflammation gives diarrhea, and that's often associated with urgency. There may be some bleeding with the diarrhea and mucus as well. And so one of the ways to know that your inflammation is controlled is you see a reduction in that symptom, whether it's cramps or pain or diarrhea. There is typically, with the inflammatory bowel disease, it comes and goes. So the medicines and treatments will control the inflammation, and then it may flare again, and that flare may come on relatively frequently or maybe relatively infrequently, but the ability to have a flare is always there. Some people can predict when their flares are going to come. There may be some relationships with stress, maybe relationships to hormone changes, and different things can affect the activity of the inflammation in the bowel, and it's quite individual. The way to know if your bowel's better is by controlling the symptoms, and that's really the main goal that most people have, is to control the symptoms. We do have other tools that are available to show that the inflammation is better controlled, and these include inflammatory markers. So there's a blood test called a CRP, there's a stool test called a fecal calprotectin. These are very useful ways of showing that the inflammation is better controlled within the bowel. There's more specific tools. You can do scopes and put cameras inside the bowel to look for the inflammation. You can use tools like imaging with x-rays or ultrasounds to look for inflammation and to show that it's controlled. But the goal is to control the inflammation, recognizing that the inflammation may recur again. I think the important thing is to maintain the treatment. Whatever got you into control, you should continue to take that. The mistake many people make is they say, I'm feeling better now, I'm going to stop all this treatment, and that is often very disappointing because the inflammation recurs again and the symptoms come back again, and you're into that cycle of trying to control it. So trying to recognize what does it take to control you and to control your symptoms, and then to continue that going forward. And that's usually a combinations of medications, dietary changes, lifestyle changes, and trying to put that together to control the inflammation as best you can. And then to use the resources that are available to you. That would be your healthcare provider, your specialist, your dietitian, psychology help and support, your family, your workmates. Those are all important tools to use to help get you through your inflammation and the flare-ups.
Great, thanks. And I want to just switch to something a bit lighter now, and I'm going to ask Beth a question. Beth, could you sort of talk a little bit, please, about what kinds of food should be included in a diet for IBD, maybe differentiate between Crohn's disease and ulcerative colitis, because I think their needs might be different, and if there are any foods that someone should avoid, anybody who has IBD should avoid?
Great question. So let's split this into when we're in remission versus when we're in a flare, because it's going to be very different for both of those situations. So when we're in remission, what are our goals? Our goals are obviously to stay in remission and to maintain a good healthy body weight, to increase our nutrient stores in our body, to optimize our nutrient intake. So the way we're going to do this is really just to eat well when we feel well. So if our symptoms are well managed, we're in remission, we want to eat well, which means that we can follow Canada's food guide, right? So everybody's probably seen that plate model, with about half our plate fruits and veggies, a quarter lean protein, and a quarter of our plate high fiber carbohydrates. We get some healthy fats in there. That's kind of the optimized way that we want to eat as much as we can. Now, when we specifically focus on some nutrients, we can look into fiber. Fiber is going to be extremely important for a lot of reasons. So we all know that it increases our satiety, which is our fullness. regulates our blood sugars and blood cholesterol. But importantly for IBD, it can increase our microbial diversity, so our gut health, as well as regulate our bowel movements, which can be really important if we're having loose stools, especially with IBD. Prebiotics specifically are fibers that feed the good bacteria in our gut. We may want to focus more on those. That comes from onion, garlic, leeks, asparagus, bananas, oatmeal, etc. A lot of Crohn's and colitis patients also focus on anti-inflammatory foods, considering it's an inflammatory condition. So again, lots of our colorful fruits and veggies are going to be really important there. The really important point here is that when we're in remission, we don't want to be having a restrictive diet. A restrictive diet is just going to be leading to increased risk of malnutrition, and this population is already at risk of malnutrition, so that's something we really want to avoid. Let's switch gears and talk about a flare. So if we're in a flare, what are our goals? Our goals are to reduce inflammation, manage symptoms, promote healing from that flare, again, optimize our nutrient intake while we're reducing some of our trigger foods. So what might be some of our trigger foods? Well, insoluble fiber is one thing we talk about a lot. It can be very irritating to the gut. It can increase our transit time, which is how fast things are moving through the gut. And of course, with loose stools, which is common in IBD, that can worsen that symptom. Lactose is another thing we talk about.
What are the insoluble fibers?
Insoluble fibers are usually the skins and seeds of fruits and veggies. So if you have a pear, for example, the inside would be more soluble, the outside skin would be insoluble. Whole grains, nuts and seeds in products like whole grains, beans and legumes, things like that can be more irritating. Good question. Lactose is another thing that we may want to reduce during a flare, but this just depends on triggers and tolerance. So because our lactase enzyme is made in the brush border of our gut lining, if we have inflammation, we may make less of it, which means we're not breaking down that lactose as well, and it's creating symptoms because it's malabsorbed in our gut. That comes from, again, dairy foods, so milk, cheese, yogurt, but there's a lot of lactose-free products on the market these days that we can go to. The good thing is that this is usually short term. So if we don't tolerate lactose, it's just in the short term. When we're outside of our flare, we can usually bring those foods back in.
Does that include things like soya milk and oat milk and those products that are so common now?
Yeah, typically those ones are lactose-free. So they don't have that natural sugar that's in cow's milk. So that would be a good option for somebody if they were avoiding lactose.
And the supplements, there's all these commercial supplements that are, I won't name names, but they're out there as supportive nutritional products. Are those okay? If you're
a lactase enzyme you could take if you were going to consume a lactose product and you knew it might give you some symptoms, that you could take a lactase enzyme at the same time and then help break down that lactose in that product and hopefully have less symptoms. Other foods we may want to avoid, caffeine and alcohol. Everybody hates me for saying this, but they are gut irritants. We all know that caffeine can be a bit of a laxative effect, so that's going to make, obviously, loose stools worse. What else? Fatty foods and spicy foods. So a lot of clients say, I actually had one client in particular say that Thai food, like he could not tolerate. Even when he was in remission, he felt it almost triggered a flare, which is obviously individualized, but especially during a flare, could not tolerate that. Sugary beverages too, they tend to be osmotic, so they sit in our gut and absorb water, which makes things move faster. So that's one we want to limit. And then in terms of how we eat, so more pre-digested foods are going to be easier for our gut to tolerate. So using blenders, using food processors, steamers, cooking the vegetables a bit better so that our body has to do less work and they're a bit easier tolerated inside our gut. As well as the frequency of how we eat, that's really important too. So a lot of IBD clients do better with 5, 6, 7 smaller meals a day rather than the standard 3 because it's a smaller volume. So we're going to have less expansion of the gut, so less symptoms are typically triggered there. In terms of what we want to focus on here, we want to focus on protein for healing. We may look towards easier to digest protein, so things like eggs, chicken, fish, tofu, over things that may be a bit harder to digest, like beans and legumes, or tougher meats like connective tissue. We also want to focus on soluble fiber. This is going to help gel up our stools. So if we're having loose stools, we can get more regularity there. If we're focusing on soluble fiber foods, again, that's oatmeal, bananas, applesauce, and we can, of course, do a supplement there too, which we can talk about a bit later. And then lastly, if the flare is severe enough, we may be considering enteral nutrition, which is nutrition through a tube into our gut, or parenteral nutrition, which is known as TPN, which is through an IV into our blood, so completely bypassing the gut if we have things like infections or obstructions where we really just need some bowel rest. But all of these come down to individual triggers. It's not that any IBD patient needs to limit all of them. It's just try one at a time and see what works for you.
I get asked a lot of questions about all these special diets that are on the media so much, and I mean, I couldn't begin to list them all: paleo and keto diets and FODMAPs. And is there any place for that in IBD?
Great question. So most diets these days are very restrictive. They take out a food group or a specific food or multiple foods. And so for that reason, I typically don't recommend them. This population is already at risk for malnutrition, so we don't want to be having diets that are going to increase the chance of malnutrition through nutrient deficiencies. So things like paleo, which is typically lower carb, keto, which is extremely low carb and high fat, we don't want to be going that route at all. However, there are some diets that may be applicable. Something like the Mediterranean diet. So following that type of diet has lots of nuts and seeds and healthy fats and lean proteins, high fiber carbohydrates. That might be one to look at. It also includes alcohol, which of course we're not gonna touch on since that can be a gut irritant. But they have shown that that can reduce malnutrition and optimize our gut diversity, which is important for IBD, reduce inflammation. So that may be a direction to go if a client needs a bit more structure in how to eat. To answer your question about FODMAPs, typically FODMAPs are more designed for IBS, so irritable bowel syndrome. There's no research for FODMAPs in IBD. So sometimes if I see overlapping IBD and IBS, I will play a little bit with FODMAPs with a client. I will not do the full restrictive diet because it's too restrictive, obviously, but that may be a time where I look at it. But they're very, like you mentioned, very distinct conditions with distinct nutrient interventions.
Okay, so the good news is we have a lot of this information available on our website. So there's the anti-inflammatory diet. We have nutrition tips for inflammatory bowel disease. There are a lot of articles on our website that you could go to. If you just go to the Living with IBD section of our website, all these articles are available and links there.
I think it's safe to say, though, that food doesn't cause IBD. A lot of people ask that. They say, what causes? Now I've got Crohn's disease or ulcerative colitis, and what causes it? And my response is, I don't think we know. We know there's these different factors, but it's not caused by food. So the food makes it worse, or can make it worse in certain circumstances, but it's not caused by that.
No, it's just individual triggers. Some people find certain foods are really hard to digest in a flare and cause symptoms, or some people even feel certain foods put them more into a flare. Again, that's not really in the science. It's more just that individualized triggers and individualized response.
So can you also touch briefly on some of the medications, the different kinds of medications, and what's used in mild disease versus moderate or severe? Because there is a range of these diseases, right? So if you could touch on that.
So the treatment of inflammatory bowel disease with medications has evolved, and it continues to evolve. There's new medications coming up year by year, and they're wonderful medications, and they offer new opportunities for control of the inflammation. So traditionally, we would use steroids, that's prednisone, and sometimes steroids through the intravenous route, and that would use to control the inflammation. And these are wonderful drugs. They work very quickly, but they have some potential side effects, and the side effects can be around mood disturbance, bone health. Some people get fluid retention, and there's some issues around steroids that make us want to not use them on an ongoing basis. But they're wonderful tools to bring the disease under control and to bring the symptoms under control. And then we have other anti-inflammatories. So we've been using things called immunomodulators. They've been around for a long time. You'll recognize them as methotrexate or Imuran or azathioprine. And these are medications that suppress the inflammation response and control the inflammation and thereby control the symptoms. Some of these drugs take a little while to work. We have things called 5-ASA, and these have been around for many decades, 5-aminosalicylic acid. So this is an anti-inflammatory that works by coating the lining of the bowel and reducing the inflammation. It works primarily in the inflammation of the colon, and the medications are delivered by tablets, and there's also rectal preparations that can be delivered through the rectum to control inflammation in that part of the body. And now we have the newer agents called biologics, and these are generally injectable, although now we're moving towards oral agents. And so traditionally they were first given intravenously and then subcutaneously, and now we're moving to oral. And there's a whole number of different medications in this family of called biologics that work to control the inflammation. Unfortunately, they don't cure the condition. So a lot of people are disappointed. They take the medications, they get control of the symptoms, they choose to stop the medications, and the symptoms come back again. And so we just have to recognize that we're controlling it, but not curing it.
So another question that came in said, is it possible to manage Crohn's disease without medication?
Well, I think it is, depending on how severe the inflammation is. And we don't think that we cure it, but we can control the symptoms. And so for some people, there's dietary factors that trigger their symptoms off, and Beth will probably have some ideas around that. Sometimes there's hormonal factors. So women during pregnancy can sometimes find if their condition can flare. It's not caused by hormone changes, but hormones do play a role. Stress is out there as being a factor, and I don't think we believe that stress causes inflammatory bowel disease, but clearly stress, whether that's sleep disturbance or work-related stress or home-related stress or whatever stress comes from, that can aggravate the symptoms, but it's not the cause of it. So there are people that can control their disease by making lifestyle changes, but it's not universally effective. So generally, depending on the severity of your symptoms and what you need to get your symptoms under control, usually that's a clue as to what you'll need to keep your symptoms under control going forward. So if you have quite significant inflammation, you require medications, then probably you'll continue to require medications to some degree going forward.
Okay, so one more follow-up question about medication is that several individuals asked this question, can I continue to take a biologic medication indefinitely? Like, is there an issue with taking it long-term?
No, we believe that these medications, although every medication in the world has some form of side effects, we believe that these particular medications have a remarkably safe profile, and the effect is really controlling the symptoms when they're active, but also maintaining that control when the symptoms are quiescent or under control. So they work both actively and then in a maintenance fashion. And so indeed, given that we believe that inflammatory bowel disease is a lifelong condition, most people do require lifelong treatment. That isn't to say there isn't a place for reducing the dose of the drugs or perhaps contemplating some drug holidays in the future, but generally our belief is that these treatments should be continued long term. The mistake people make is they abandon the treatments, their disease flares, and then they're struggling to get themselves out of that flare, and it's always disappointing. You lose ground, you lose work, you lose opportunities for play because your symptoms are active. So maintaining that control is very important. And it really joins with other conditions that have the same chronic pattern, whether it's asthma or diabetes or high blood pressure. These are conditions that are chronic and they require chronic treatment to control them.
And one other question about medicines, and that was about these JAK inhibitors. What do you think? Are those used well in IBD?
Well, so there's a growing number of drugs that are becoming available, and it really is a credit to the pharmaceutical industry and the research teams that are looking at these products, and they're turning out new products year by year, and they each have different attributes and advantages and perhaps disadvantages. Not all drugs work for everybody, not all drugs work for every condition, and so we find that some drugs are more appropriate for an individual with certain types of inflammatory bowel disease, and it's something to talk with your healthcare provider about what's appropriate for you. Some people are attracted to drugs that are delivered orally, and the newer agents are becoming more orally available, but some people find that they do better with injectable drugs, and these can be either intravenous or subcutaneously delivered. And so there's a lot of different choices, and it's something to work with your healthcare provider and try to find out what's the best one for you, and then work with that particular product.
Thanks. And so a question for Beth. Someone has asked, what are some of the tips to reduce bloating?
Mm-hmm. Bloating is a super common GI or gastrointestinal symptom. So first of all, what is it? It's kind of that sensation of abdominal swelling. I think most of us have had bloating at some points in our lives. It's, you often get people saying too, like, it feels like I'm 6 months pregnant, like that type of feeling against our abdomen is really uncomfortable. So what can we do about this? There's a few different areas we can focus on. First of all, what we eat. So we can consider things like spicy foods, fatty foods, they can contribute to bloating, carbonated beverages, since we're consuming more of those bubbles, that's going to contribute to air and contribute to bloating. Potentially FODMAPs, again, that's more irritable bowel syndrome, but we may have some food intolerances there that we do need to dive a little bit deeper into. We also consider how we eat. So eating really quickly, eating while we're talking, distractedly eating. Chewing gum is another big one. Using straws. So when we use a straw, everything we're sipping up before the actual liquid is air, right? We're adding more air to our system that way. And then chewing not well enough is another big one. And clients think I'm crazy for asking them this, but I always ask them, are you chewing your food? And they're like, of course I'm chewing my food. That's how it works. But we have to consider that if we're chewing less than 10 times, we're not digesting that food very well mechanically, right? And if we're chewing 20 to 40 times, we have literature to say that we are breaking it down very well, and it's more easily digested in our system. So that's one thing to focus on too. And I encourage people to try that at home, like take a bite of food and see how many times you chew. I've done that before, and it's like 4 to 6, which is atrocious. So we need to work on that to reduce bloating. Lifestyle is another big thing, like you've touched on, Dr. Gray. So stress, when we're in that fight or flight sort of sympathetic response, we shunt the blood from our gut to our muscles, right, to run away from whatever is scaring us. And then our gut doesn't do as well at its job of digesting. Again, exercise and physical activity. So I always tell clients, when we move, our gut moves. So keeping active, we move things in the right direction, and that can help pass gas and reduce bloating. Tight clothing is another one that people often don't consider, but it can compress our abdomen. So, you know, throw out the skinny jeans and get in some stretchy leggings or some sweatpants, something that's more comfortable. And then lastly, smoking can also contribute to bloating. So that's an important one. Often I tell people to try ginger or peppermint tea. Those can be good ones to help kind of reduce some of that pain in the gut and keep things moving.
Given that nutrition is so important when you're talking about diseases of the GI tract, many of my patients are wondering where to get information and help with the dietary management for their condition, and they don't know where to access. They see nutritionists. I'm never quite sure what a nutritionist is, and then some people get advice from their mother-in-law, which of course is always good, but sometimes you wonder what's the best source of advice for nutritional questions in inflammatory bowel disease?
Yeah, it's a great question. So we do want to be going to a registered dietitian in comparison to a nutritionist. So a registered dietitian is a regulated, protected title. We have years of experience in education, lots of supervised hours in an internship, a national exam we've written. So it's very regulated. A nutritionist is anyone. You could be a nutritionist, you could be a nutritionist, anyone could be a nutritionist because it's unregulated. Other than in Quebec, where typically registered dietitian isn't regulated as well, so it's a bit different there, but generally in Canada, you want to go for a registered dietitian. In terms of where to find information, we have the BC Dietitians website as well as Dietitians of Canada. And you can search for specific GI and digestive health dietitians there through their search engines. So I would definitely recommend checking those out. On top of that, when you do find a gut health GI dietitian, I do recommend reaching out and asking if they do specifically work with inflammatory bowel disease, because a lot of dietitians say, yeah, I'm a gut health dietitian, I'm a GI dietitian, but they don't really work as much with IBD. They work more with food intolerances and other things. So definitely make sure you get that question answered so you're with someone who's really going to help you.
And other resources that you recommend that they could go to?
Yes, definitely. Another one is going to be on badgut.org. If they search in recipe book, the first thing that comes up is the IBD kitchen book. So inflammatory bowel disease kitchen book. This is full of recipes. I know a lot of clients struggle with just the extra burden of, I don't know what to make, I don't feel like making things, what's going to feel good on my gut, what's going to not lead to many symptoms. That's why this book is great. It's made by a chef and 3 registered dietitians, so it's obviously very evidence-based too, which is always good. And so if you go to the website, you can download it for yourself, and I highly recommend doing that.
Great. And so for Dr. Gray, another question that came in is, can IBD affect fertility, especially for women? And maybe you want to touch on men as well.
It's a good question. I mean, typically inflammatory bowel disease affects young people, so in that 15, it can affect any age, but often the onset is in that 15 to 30 year age, and that's the time when people are having families and trying to get pregnant. And clearly we do see some effects on fertility. It's not universal, but there's the effect of the fertility can be diminished, particularly if the disease is very active and there's a lot of inflammation, so that can affect a woman's cycle and her ovulation, and so there can be effects on the ability to get pregnant. Sometimes there's problems around having diarrhea and other problems that interfere with intimacy that can be problematic for people, and that can indirectly affect fertility. Some of the medications, now these are the older-fashioned drugs like sulfasalazine, which we don't use very often now, can reduce sperm count in men. It's reversible. If you stop taking the drugs, that effect goes away. So there can be some effects on fertility for both men and women. But I think the key is really the fertility is generally normalizes when the disease is controlled. And so getting control of your symptoms with whatever means, whether that be medications, dietary changes, nutritional support, those are all important parts of the control of the symptoms, and that then will go a long way towards improving fertility. The question often comes up is, what's the effect of inflammatory bowel disease on being pregnant? And there can be some increased risks of flaring your disease when you become pregnant, and we know that there's some sort of hormonal connection between becoming pregnant and the symptoms of inflammatory bowel disease, whether it's colitis or Crohn's disease. So some women will find that their symptoms will become worse when they become pregnant. It speaks to the idea of trying to be as well controlled with your inflammatory bowel disease when you do get pregnant as it can be possible. So the ideal is to get good control of your disease and maintain that control while you're becoming pregnant, and then to maintain that control during your pregnancy. So this is not the time to abandon your drugs and stop everything because you're pregnant. These drugs are generally very safe with pregnancy, and there's a lot of literature and investigation supporting that. And by all means, talk to your healthcare provider, but do not stop the drugs simply because you're trying to get pregnant or that you now are pregnant. You're better to control your disease while you're pregnant, and it gets a much better outcome for both yourself as the mother and the upcoming baby as well.
Great, thank you. And another question that's come up several times is, how does sleep and regular sleep affect my inflammatory bowel disease? Wow,
that's a great question. I mean, sleep has so many effects on our body functions in so many ways, not just inflammatory bowel disease. I don't think there's a lot of studies that show specifically with inflammatory bowel disease, but experience would say that if you get good quality sleep, that goes a long way to control inflammation, whether that's inflammation in your bowel or other parts of your body. So recognizing your sleep pattern, recognizing your sleep needs is very important, and then trying to find a way of getting that sleep. So this is the time to try to find a strategy for improving your sleep, giving yourself time to relax and go to bed, giving yourself time to sleep, try to get away from your devices, get away from family members that maybe prevent you from sleeping well, but trying to recognize that sleep is very, very important for controlling bodily health, including inflammatory bowel disease health. So you want to try to maintain that sleep pattern and finding out what you need, and don't be afraid to take that amount of sleep. And on the other side of the coin is physical activity. So being physically active, there's a lot of benefit from physical activity, both for muscle health and bone health, but also emotional health. And so maintaining that balance between sleep and physical activity, balancing your work life so that you try to maintain as much of a regular pattern of your sleeping and working and eating, and trying to keep that pattern as balanced as possible is very, very important.
And so a question for both of you is about the microbiome. This question comes up all the time. Mm-hmm. And is there any advice as to what you should do to manage and mitigate what's going on in your microbiome? Maybe you could talk first, Dr. Gray, about what that is, and then both of you can maybe talk about what you can do to contribute to a good biome.
So this is a wonderful, very topical area, and there's so much awareness now of the microbiome. And what the microbiome is, that whole blend of organisms, whether they're bacteria or parasites or viruses that live within our body and primarily within our GI tract. It's said that we have 1 kilogram of organisms within our gut. They're normal, they're meant to be there. There's all sorts of different organisms, and that's what the microbiome is. Obviously, the microbiome is different for different people. When you travel, your microbiome will change as you get exposed to different foods and different organisms. And this is not speaking about abnormal organisms. This is not infections. It's just the blend of organisms that you have within your GI tract. And there's a lot of research that's being done now to try to understand what differences in that microbiome might have on affecting your health, and including your GI health, and including perhaps inflammatory bowel disease. I think the science is still quite early and we just don't have the answers, but it's certainly a very important area, and clearly the microbiome responds to the different foods that you eat and the different organisms that you're exposed to in your day-to-day travels and work and so on. So I think there's a lot of research, so stay tuned on this one.
Yeah, I find it fascinating how much diet and lifestyle can play a role with our microbiome. So when we think about diet, we might think about lots of probiotics in the diet. We think about things like sauerkraut and kimchi and miso and yogurt even, that can provide probiotics, those healthy bugs, into our system. And then we think about prebiotics too. They have to have food, right? We have to feed them with something, so we feed them with tons of fiber. Then they ferment it and they create those beneficial byproducts such as short chain fatty acids, which are so important for our mucosal healing, which is really important in IBD as well. So that's kind of the diet part. And then we can think about lifestyle there as well. You've touched on physical activity and sleep. Stress, we know that gut-brain connection, that's another area that research is exploding in. These two organs are connected through a vagus nerve, and they are just in constant communication. So I always tell clients, it's like you and your best friend that text all the time, and it's like back, forth, back, forth. That's this, right? Your gut and your brain, and your gut is actually considered your second brain for a reason. So everything your brain goes through, your gut is inevitably going to suffer from as well. So stress can induce things like inflammation and potentially put you into a flare, which is why it's so important for IBD.
Is there a place for probiotics in IBD? Like supplemental probiotics? There's so much in the drugstores and in the grocery stores around probiotics. Is there a place for that?
Yeah, great question. So probiotic supplementation, we have to be careful with how we look at this. So yes, with the association to IBD, with our gut health, we may think everyone should be on a probiotic. We really want to go by the science though, and what the literature says. So there are two in particular, Florastor as well as VSL number 3, which is also considered Visbiome, which do have some research for colitis specifically. There's not really a lot of research for Crohn's and probiotics, but colitis, potentially those two could help. I find it's a little bit individualized with clients as well. Some people swear by them and find that they reduce flares and make flares less severe, but again, that's very individualized, and we want to make sure we get one with good science behind it to see if it helps.
That's my sense, is science is really quite deficient in this area, and probiotics are all so different, and the way they're manufactured is different, so there's not one probiotic. My sense is that if a probiotic gives you benefit, then by all means continue it, but if you don't get benefit, then by all means don't keep taking it. You save your money and don't keep taking it, but if you get a benefit, then keep on with it.
And just while you mentioned that, I mean, in terms of length of time, I usually tell my clients at least 4 weeks. Give it at least 4 weeks to see if there's that benefit. If not, drop it. If there is, continue.
So don't be afraid to stop it.
So I have a question for both of you about supplements. We've had a lot of people who ask us about what supplements. Now, I've heard that supplements just give you expensive pee, but I don't know if that's true, or whether these supplements are really, there are some that are that you would recommend for someone who has inflammatory bowel disease, and would it be dependent on their stage of IBD, whether they're in remission or whether they are during a flare, or just in general for IBD? So if you would both speak to supplementation, if this is something that those who have IBD should do.
Yeah, it definitely can give you expensive urine, so I'm glad you brought that up because that's a common thing that we talk about. First and foremost, we want to talk about supplements with our care team, right? Because there's specific brands and doses and safety and everything that we want to be sure of before we just jump into one off the shelf. First of all, one I get talked about a lot is going to be aloe vera. I don't recommend it. A lot of people say it's very soothing to the gut, but in reality, it's very irritating to the gut, especially if somebody's in a flare. So just first and foremost, that's one that's a big no-no. In terms of things we may want to try, which again is very individualized, soluble fiber may be really great to gel up those stools if we have loose stools. Things like psyllium, metamucil, which has psyllium as the main ingredient in there. That could be a helpful one. L-glutamine is another one that comes up often. It's an amino acid that's specifically good for those enterocytes, so those cells in our gut, good for the mucosal healing, so that may be something we consider. Omega-3s are an interesting one that comes up a lot too, due to their anti-inflammatory effect. I typically say let's go food first, because there's not enough evidence to say a supplement's going to put us into remission or keep us in remission or prevent a flare. So we look at things like fatty fish in the diet, so salmon's a great source, chia seeds, hemp hearts, flax seeds, walnuts. These are all great sources of omega-3s that we can get just through the diet. We may consider just a very generic multivitamin for somebody if they have low intake and low appetite, and we just kind of want to make sure some of those micronutrients are covered. Iron is another one we may focus on due to low intake and inflammation, especially if it's in our duodenum and jejunum, so those first two areas of our small intestine. Potentially blood loss could be another reason we're losing iron. So again, we can look at foods, but iron's difficult to bring up through foods alone, and we may need to look at a supplement for that, and then monitor through the blood work to see if we're bringing those levels up adequately or not.
The other important thing is to recognize that some people have specific deficiencies, and B12 would be one. Mm-hmm. So we know that Crohn's disease often involves the bottom of the small bowel, and that's where B12 is absorbed. And so if you have a significant inflammation in that part of your small bowel, you may not be able to absorb the B12, and that can be supplemented either orally or by injection. And so that's something that your practitioner may want to monitor if that's the area of your body that is inflamed. Mm-hmm. And then the other specific ones I think are calcium and vitamin D that often are important for bone health and for and can become deficient in people with difficulty absorbing. Mm-hmm. Iron is now available both orally and intravenously now, and I think the intravenous process, a lot of people have had trouble absorbing or tolerating oral iron supplements, and so you can talk to your practitioner about accessing intravenous iron replacement, which is becoming more and more available, and it so bypasses a lot of that GI side effects that are so uniform with oral iron supplements.
Absolutely. Yeah, and we may also consider another one I see really often is liquid nutrition, so things like Boost or Ensure, which are on the shelves and widely available. It kind of packs a lot of protein and calories and micronutrients into a very small volume. So when we have low appetite and we're not able to eat much, that's a nice way to get quite a bit of nutrient density.
And they're lactose-free, aren't they?
A lot of them can be lactose-free, yeah, for sure. Electrolyte drinks are another one, right? So if we're having lots of loose stools in the day and losing lots of electrolytes and dehydrated, we may consider having more electrolyte drinks in the day too.
And we have reviews on these products on our website too. Mm-hmm. So,
yes.
So if someone wants to drill down as to what would be the best product for them, they could look through those things up on badgut.org.
Mm-hmm.
too. Yeah. So Dr. Gray, what's the role of surgery in treating IBD?
A lot of people ask that. They just say, well, cut it out. I'm so fed up with this disease. Why don't you get a surgeon and cut it out? And there is very much a place for surgery in inflammatory bowel disease. It's done far less now than it was 20, 30 years ago. I think the important thing to recognize is that surgery doesn't cure you of the problem. So if you have inflammation in your bowel and you remove a part of the bowel, other parts of the bowel can still become inflamed. Now, the exception to that would be if you have ulcerative colitis and you no longer have a colon because the colon's been removed, then that does cure you of the colitis because you don't have a colon to get inflamed. But for example, with Crohn's disease, it can affect any part of the GI tract. So cutting out a part of it doesn't then prevent other parts of it from getting inflamed. So there is a place for surgery, and so surgery may be required if there's a stricture or a narrowing in the bowel that won't open up and it blocks the bowel. Sometimes people develop abscesses from inflammation penetrating through the wall of the bowel, and surgery is required for control of this infection or this abscess, but it's not done nearly as much as it was before, and sometimes it's done urgently if there's a complication like an abscess or obstruction, but it's not done as much electively as was before. But there is a place for surgery. The surgery for ulcerative colitis is removing the entire colon, and of course that leaves you without a colon, and that means that you then have to have some sort of a mechanism of passing your stool. So sometimes that leads to what's called an ileostomy, which is a bag on your abdominal wall, and you poop through the bag. There are techniques then of creating what can be thought of as an artificial rectum, but it's not really artificial. It's using other parts of your bowel to create a rectum when you don't have a colon. So you still then would poop out your rectum, but it's not with a colon still there. And that sometimes leads to all other changes. It can change the microbiome of your bowel, and this artificial rectum, which is called a pouch, can sometimes get inflamed and cause problems, and there may be issues around alterations of the microbiome that affect that inflammation in the pouch. So surgery has a place, but it's not necessarily a cure, so it's sometimes a thing that people do have to reach out for, but it's not always the ultimate goal or treatment for that. Nowadays, with the amount of medications that we have available, there are so many other options that we choose first of all before resorting to surgery.
And so if they've had surgery, will that affect the diet then? And this is the case where they really should see a registered dietitian.
Definitely, it could affect the diet for sure. And again, we go back to fiber. We may need to modify the fiber in our diet. So if we're finding we're moving stool quite quickly through our body, we may need to limit some of that insoluble fiber again. However, if we're not having triggers and we're not sensitive to it at all, we want to bump up the fiber. You mentioned strictures, so we may need to, again, lower overall fiber intake and give it some rest to not leave a risk of obstruction there. And then, of course, we look at our nutritional supplementation through potential enteral nutrition through the tube, as well as parenteral nutrition through the IV into the blood if needed, and if it's severe enough and we really need that bowel rest. Another thing to consider if we don't have a colon is hydration. We do a lot of our water reabsorption in our colon, so making sure we're really adequately well hydrated is going to be super important too.
I find that quite a bit of people with Crohn's disease often are told, oh, you need to have a lot of fiber because don't you know fiber is good for your bowel? And it certainly is, as you've said, Beth, but I think there is one exception to that. People that have narrowing of their bowel, usually around Crohn's disease, where the bowel is narrowed and things don't pass through, and then they start eating a high fiber diet and it starts to plug up, and then they start getting cramps and pain. And so those people need to be reminded that for their situation that maybe fiber is not the way to go. And I'm always struck by the people that go to a movie and have a bag of popcorn, and then 4 to 6 hours after the popcorn, it jams in that piece of bowel and they start getting cramping, and they're quite awkward and uncomfortable for them. So they need to be reminded about the benefit of fiber restriction for that situation.
Absolutely. Yeah, very important.
So Dr. Gray, another question. Is Crohn's disease or ulcerative colitis, are they confined just to the bowel?
Well, and that's a very good question, because we do know that by definition, the inflammation of the bowel begins in the bowel, but we know now that it can affect other parts of the body. And so one of the most common areas of the body that can be affected by inflammatory bowel disease would be the joints. And so you can get arthritis, so that's inflammation or pain in the joints, and it can be pain in the spine, and we call that spondyloarthropathy, or it can be pain in the joints, particularly the large joints like the hips and shoulders and knees. Some of these arthritic symptoms can go along with the active inflammation in the bowel. So when your bowel's active, your joints become active. And in other individuals, the joint complaints can be quite independent of the inflammation in the bowel. But there is a relationship, and we call these extraintestinal manifestations. So they're outside the bowel, but they're related to the bowel inflammation. Other areas that are in that group of extraintestinal manifestations would be skin changes. So as people can get painful lumps on their shins or on their elbows, we call that erythema nodosum, and you may recognize it's a painful bump, and it reflects the inflammation. For some reason, the other parts of the body are responding to the inflammation in the bowel. You can get ulcerations on the skin, you can get sore eyes, and these are all things that are related to the inflammatory bowel disease, but not necessarily active at the same time. The treatments that we use for inflammatory bowel disease often will then improve these extraintestinal manifestations. So for some people, the joint complaints can be more troublesome than the bowel complaints, but they're related to each other, and they fall under that heading of extraintestinal manifestations of inflammatory bowel disease.
So Dr. Gray, what's the future hold for inflammatory bowel disease?
Well, I think it's exciting. I think many people who have inflammatory bowel disease feel very alone and isolated. They feel very disappointed that they've got this condition, and it can be very depressing and frustrating. But I think it's important to know that there are ways of controlling it, and the tools are available. You need to advocate for yourself. You need to work with your healthcare providers to access these different tools, and know that there is active research being done around the world, both for management of inflammatory bowel disease, management of complications of inflammatory bowel disease. There's a lot of work being done on trying to understand the causes of inflammatory bowel disease. And so that this research, while it's not immediately available, it's still coming, and you can look forward to increasing opportunities for medications and for diagnostic testing that will help to deal with the condition and make life better for people. So I think, again, be optimistic. I think it's exciting, and I look at the changes over my career in both diagnostics and treatment options. It's been quite remarkable, and I think we can see more of that going forward in the future.
All right, so Dr. Gray, is there anything else you'd like to add to what we've been talking about tonight? Any other things that have come to mind from your patients when they talk to you and ask you things?
Well, I think what we've been talking about is inflammatory bowel disease, and it's important, it's difficult, it's challenging for you as a patient, it's challenging for your family members, it's challenging for your workplace, and I think the important thing to know is that there are treatments, and the treatments are effective, and the amount of treatment that an individual needs varies, and some people need a lot of treatment, some people need little treatment. The important thing is to recognize there are treatments and to work with your healthcare providers and your support team, whether that be practitioners, dietitians, physiotherapists, psychotherapists, and try to find the techniques and the tools that make your disease best controlled as you can be, and not give up. You need to keep working with it, because there are ways of controlling the inflammation and maintaining a much higher quality of life for you.
And so Beth, is there anything you want to sort of talk about in summation of what we've been talking about today?
I would just really advocate for people to reach out to see a registered dietitian. I think people undervalue how important diet plays a role in any gut condition, but especially inflammatory bowel disease. And if nothing else, just to be a sounding board for you and an emotional support, but as well, of course, looking into diet and how we can mitigate symptoms and just help you feel better. And we're on your team, so I just hope that people do reach out.